You're listening to Medscape's In Discussion series on systemic lupus erythematosus, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Maureen McMahon. Dr. McMahon is a professor of medicine and associate chief of rheumatology at the David Geffen School of Medicine at UCLA. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I am Dr. Maureen McMahon. Welcome to the Medscape In Discussion podcast series on systemic lupus erythematosus. Today we'll discuss the epidemiology of SLE with our guest, Dr. Peter Izmirly. Dr. Izmirly is a professor in the Department of Medicine at NYU Grossman School of Medicine and co-director of the NYU Lupus Clinic. Thank you for joining us today.
Thank you very much for inviting me. It's very flattering. I appreciate it.
Well, again, when I think about epidemiology and lupus, I really think of all the great work that you and your team have been doing. You know, I know when I first started in lupus and I was a young faculty member and I remember writing up a talk on lupus for the medical students, I remember some of the data on prevalence and incidence of lupus were really varied. Lots of different studies had widely different numbers. So I really appreciate a lot of the work that you've been doing with the CDC registries. But I was just kind of curious how that got started and also a little curious to know the process of what you did to gather that data.
Part of the reason it got started was exactly what you were saying, that the data available on the epidemiology of lupus prior to the early 2000s, when these registries started getting up and running, were kind of all over the place. And part of it is, right, there's no sort of gold standard for the diagnosis of lupus. Like cancer, you have biopsies, which are actually reportable in a lot of states. Infectious disease, you have a culture or a blood test. Diabetes, you have an A1C. But for lupus, right, I mean, we all know how, sometimes it's very difficult to diagnose lupus. So between that and the different methodologies of the prior studies had different demographics they were targeting, different case finding sources, different states with different populations, and how they're doing it self-report, and it led to a variety of different results. And so somebody in government became interested in it, and the money was appropriated, I believe, to the CDC. And every site, with the exception of the Indian Health Service, which was slightly different, was a collaboration between a city or state Department of Health and an academic medical center. So the first two sites were out of Michigan and Georgia, and they partnered with University of Michigan and Emily Summers and Joe McCune, and Emory and Sam Lim and Christina Drenkard. And their catchment areas had very large white and Black African American demographics.
Uh-huh.
And so they were going to be able to get credible estimates on those two important demographics. But at some point in time, which was very fortuitous for me, they realized that they weren't going to be able to capture data on two of the faster growing populations in America, Hispanics and Asian population. And so they put out an RFA for two more sites. And I was very fortunate to get funded at NYU. And we partnered with our city Department of Health, which is actually a separate entity from the New York State Department of Health, and then Maria Delara at UCSF. So we were all tasked with finding the incidence and prevalence of lupus. And then there was also a fifth site, the Indian Health Service, which was actually as a branch of the federal government, I think. They had a separate mechanism. So it was sort of like an internal funding. We were very fortunate to come second. So we used a harmonized data dictionary that was already really developed and fleshed out by the Michigan and Georgia teams. And so we use like a harmonized data dictionary with how you define arthritis and malar rash and all the variables. Because at the time we did this, which was prior to 2012, when the SLIC classification criteria came around, we used a 1997 revised ACR classification criteria.
Sure.
But the SLIC criteria was in development, and they allowed us to look at their variables that they were discussing. So we all collected the vast majority of those classification criteria variables. So what we did is we went to case finding sources. And so we went to hospitals in our catchment area, and we went to all the rheumatologists in our catchment area, And we also did some nephrology and dermatology. It was a little harder to do that for some of the sites, especially like New York City and dermatology. I mean, there's like 400 of them. We also got population data sets such as state discharge database, the US renal data system, vital records, which is death certificates. So we had those access to that data. We also approached pathology for renal biopsies at various sites. We trained these medical abstractors very thoroughly. And unfortunately for New York City, we had all MDs who were looking to land residency spots. So we didn't have to actually teach them the language of what serositis and whatnot was. And we trained them, and then they went to the various case finding sources with the data dictionary in a computerized form and went through every chart page by page and abstract labs, arthritis, whether they had a kidney biopsy, what it showed, proteinuria, all the various classification criteria.
Wow.
And then in the end, we just did a simple numerator denominator.
What a tremendous amount of work.
Tremendous. And the manpower was incredible.
Yeah, it would take years to do all that. Very systematic and very thorough approach, I think, really speaks to the quality of the data.
And we did quality assurance and quality control. So abstractors continued to be monitored to make sure that they were slacking or losing their skill set over time.
So why don't we go over some of the things that you found? I'm especially interested in the prevalence data. And I believe you took all of the different sites and combined them together in one meta-analysis to get a combination of data.
In total, we had 5,417 identified cases of lupus who met the ACR criteria from the various sites. The overall prevalence of lupus was in the meta-analysis was 72.8 per 100,000 person years, with a confidence interval that ranged from 65.3 to 81.0. And women, as we already are well aware of, were 9 times higher than males. The prevalence rate for females was 128.7 compared to 14.6 per males. And overall, the highest rates were seen in African-American Black females and then Hispanic females. Now, while the American Indian Alaska Native, because the way their methodology was, is that they only targeted that demographic. So they weren't actually part of the meta-analysis, but given their methodology was similar, we included their data as a comparison. And their female rate was actually the highest at 270.6 per 100,000.
Wow. Had there been previous data on that in that population?
Very little, which is again why they funded Liz Ferrucci and the Indian Health Service to get that data. Their methodology was a little different because of the way you have to capture those demographics. But it did provide very good, credible data on that demographic, which really hadn't been studied very much at all.
And then I believe you went and looked at what that would translate to in the 2018 census.
Yeah, so we applied the various rates for both males and females to the corresponding census demographics for 2018, which was the most currently available at the time that we published this paper. And we came up with an estimate of 204,295 individuals had ACR classification criteria diagnosis of lupus, with a range of 160,902 to 261,725. That number hovers around what in America we classify as a rare disease, which is 200,000 patients.
Right. Yeah, that's interesting when we think about, we're so fortunate currently to have so many clinical trials in lupus, but those numbers, I think, really give us an idea of, how many patients are out there when we're thinking about trials and recruiting for trials.
We did in our original paper provide data using the SLIC definition for lupus, and it was higher. It provided higher rates across the board for lupus. And then we actually did the recent UR-ACR classification criteria in a subsequent paper, and that was in between the ACR rates and the SLIC rates. In that paper, it's sort of interesting, I know that there's a lot of emotion around the difference between using classification criteria for diagnosis and some rheumatologists with a gold standard diagnosis. I mean, we all don't always see eye to eye on lupus. I mean, even in the derivation of that UR-ACR criteria, there's a paper And there's a table where they have mock cases and they look at patients. These are lupus experts saying whether they have lupus or not. And, there's clearly patients where everyone agrees and everyone says doesn't have lupus. But there was a handful of cases where in the middle where like people are like, yes, this person definitely has lupus. And then corresponding amount was like, this person absolutely doesn't have lupus. So I think, with classification criteria, it can help resolve some of these discrepancies. In that paper, we went through all various permutations of who met EULAR only, who met ACR only, and who met SLIC only. And I find it hard these days to come up with any scenario now that somebody reasonably thinks has lupus that doesn't meet at least one of those. The only thing that jumps to my head is like a low titer ANA, like of 1 to 40, and then two strong things like DNA and arthritis, where if that ANA was 1 to 80, you'd be like, all right, they meet UR ACR criteria. But because it's 1 to 40, it doesn't. I mean, that if somebody wants to label that lupus, I'm not going to like roll over and scream and,
Yeah, I think that's a really good point. And I think these classification criteria are important for studies like these epidemiologic studies or other studies where you're really trying to have, some kind of standard criteria. But I think when it comes to the actual patient sitting in front of you, it's kind of your clinical judgment, and having these different tools can help us figure out what to do with our patients on an individual basis, I think.
Yeah, I totally agree.
Pete, we've talked about the prevalence in the population. I believe you also looked at the overall incidence of new cases of lupus in the population.
Yeah, so we basically did two papers. And so the prevalence, which is, again, the number of all cases in the population at a given portion of time. And then we looked at the incidence, which is the number of new cases per population at risk in a given person of time. We pooled all the data. And so the pooled incidence rate, using basically the exact same methodology and the same studies was 5.1 per 100,000 person years. And again, was higher in females than males. It was 8.7 versus 1.2. Mm-hmm. And again, the highest, was in African-American Black females, and then actually followed by Asian Pacific Islanders, and then Hispanic, and then white females. I think one of the things that both these studies did is that because of the pooled numbers, we were able to provide rates for males in both studies, which I think was a major advantage, because a lot of the epi studies largely focused on female, given the ratio. And again, we did the estimates of how many people would be newly diagnosed with lupus in 2018, which was, again, at the time we did the study, the most current census data available. We estimated applying the various rates to the various corresponding proportions of the census data. 14,216 people would be newly diagnosed with lupus in the year 2018.
I think that's really interesting data. And I appreciate your point about the incidence in males, incidence and prevalence data that you were able to obtain in males. Just out of curiosity, do you have any information about age of those patients?
We're actually, believe it or not, working on that paper right now. We have these quarterly calls with the CDC cohorts, and one of the investigators made a comment that we don't have the meta-analysis or any data very good about like the age breakdown. So each site did provide in their individual paper the incidence and some even the prevalence based on ages, but for reasons that are long and complicated and too boring for your audience, we did not do this for the original papers.
Got it. I also thought that there was a lot of interesting data that came out of the various individual studies looking at causes of death in lupus patients. And I know that there was a study done by the group looking at the California lupus epidemiology study. I was wondering if you could talk a little bit about what they found about causes of death in lupus patients.
Yeah, well, they did actually two studies. One that showed that the rate of death was very high in the Hispanic and Asian demographics, which hadn't been shown before. And then they subsequently, in a follow-up paper, explored the causes of death. And this was out of the CLUES study from the California site. What they showed, which I think many of us in the lupus world that are available are already sort of semi-knowledgeable about, is that cardiovascular disease was actually, the leading cause of death across all racial ethnic groups, followed by underlying rheumatic disease, and then third, like hem-onc disorders. The underlying cause of death was 3.63 times higher amongst lupus cases than the general population. and cardiovascular deaths for those with lupus were 4 to 6 times higher for the Asian and Hispanic demographics with lupus, respectively, compared to the general population. And that sort of was corroborated, at least in the Hispanic population, by a paper that our team was working on at the same time, coincidentally, and that was recently published.
Why don't you talk a little bit about that?
So, we had all this cardiovascular data in our surveillance program that we collected. Given the surveillance nature of this Manhattan Lupus Surveillance Program, we didn't have traditional cardiovascular disease stuff like smoking and diabetes and high blood pressure. We because that's not really related to the diagnosis of lupus. So we unfortunately did not have that data available. What we did was sort of like, instead of a standardized mortality ratio, we did a standardized like cardiovascular ratio. We compared like a ratio for how many people in various demographics who had lupus had cardiovascular disease, and then the control would be an NHANES, either national or New York City, who also has cardiovascular disease. We also saw, similar to what my friends in California showed, that the Hispanic demographic is a high rate of cardiovascular disease compared to the population as a whole. And in fact, it had the highest rate of cardiovascular disease compared to the population as a whole. If you compared it to the New York City NHANES, it was 5.5. And if you compared it to national NHANES, the rate was 4.3.
Dear to my heart, but something that we've really been recognizing over the last several years is how much of an impact cardiovascular disease can have in our population.
And one of the other things we also showed is that, we looked at various breakdowns. And so young males had much higher rates. So if you had lupus and you're a male, age 20 to 49, irrespective of your race or ethnicity, your risk of having a cardiovascular event, defined as like a heart attack or a stroke, was 11.3 times higher than if you didn't have lupus.
Wow.
And we showed that, again, Hispanics had young Hispanics had 10.9 times rate of if you had lupus compared to the same demographic in the absence of lupus.
We've had some of that data in young women. This is one of the first studies I remember seeing that really also described that risk in young men.
I mean, that's one of the luxuries, again, of some of the epi work that myself and my colleagues at the CDC registry is because you did a large population. I mean, part of the RFA required that your catchment area had to have 1 million people in it, at a bare minimum. And then you captured all the, to the best of your abilities. I'm sure we probably missed some, none of this stuff is perfect, but as many lupus patients as you can, and you have a relatively substantive population of males with lupus. And so it gives you some power to look at this stuff.
I also thought that some interesting data came out looking at the overall prevalence of different disease manifestations in lupus patients. There was one study from the California group. Can you speak a little bit about that?
They looked at their California Lupus Surveillance Program registry and broke down when sort of the severe manifestations develop, and looked at the different demographics and their risk factors. And some of the interesting findings is that African Americans, Asian Pacific Islanders, and Hispanic patients respectively had the highest risk of developing lupus nephritis, and that Hispanic patients and Asian Pacific Islanders also had a higher risk of developing antiphospholipid syndrome.
That's really interesting. And I don't remember seeing previous data that gave us an idea of severe findings such as renal involvement or APS in the Asian population.
In the various registries, they did publish the criteria. So for example, in New York City, and I know Georgia and Michigan and California also did this in the original papers, they did look at the various ACR criteria, and in every registry, all of the minorities, African Americans, Hispanics, and Asian Pacific Islanders, had the highest rates of lupus nephritis, and in fact, like approaching almost 50% in some of the studies. But in this paper, they showed the time, I believe, to the development of lupus and the risks of those populations developing it.
Thinking about wrapping up our discussion, I was curious to know if your involvement in this work has changed the way you practice or the way you think about your patients, or is, kind of changed the way you see lupus in general in the United States.
Yeah, I mean, a few things. Even using some of the higher estimates that you might have generated from SLIC or the UR ACR criteria, there's not a lot of lupus patients out there. And when you have like 8,000 CAR T studies trying to recruit some of these same sick patients, it makes you wonder how sort of practical it is. I mean, I'm not displaying it as if there's only so many patients out there for these various studies. We don't want patients to suffer, and we don't want them to have delayed diagnosis. And I think making like the frontline people, which are not us really, they're the ER, urgent care, primary care physicians. When you see like a young African American woman who has joint pains, or you do a urine analysis for maybe a UTI and there's like 4+ protein in it, you should start thinking maybe this patient has lupus.
Yeah.
And I think part of it, I hope, came out of and there was a decent amount of publicity around the publications, was that, maybe the message to get across to the frontline people is that young women are certainly at higher risk for developing this disease, especially amongst certain demographics. And you should think lupus when you have unexplained kidney disease or arthritis or some rash that, isn't obviously some fungal something or other. That
I think that's a really good point. And I think along those lines, if you have a young patient who comes into your office with joint pains, to remember to check for proteinuria and see if there could be proteinuria there, and just kind of remember some of these manifestations that we do see more commonly in patients.
I've learned a lot. I've learned a lot about epidemiology. I'm actually not a card-carrying epidemiologist like some of my colleagues are on. So I've learned a lot about the nuances of epidemiology and how difficult it is to study some of these stuff, especially a disease like lupus. I mean, if we had like some blood tests that was end all be all, then this could be done much quicker, right?
Yeah. But instead, you had to get your boots to the ground and go out there and do all that work.
My colleague, yes, we all had our boots there. There's a lot of people working on this.
When I think about the effort you described, it's really tremendous. Well, thank you again for talking to us about all of your effort and everything that you and your colleagues learned. Today, we've talked to Dr. Izmirly about the epidemiology of lupus. I think we all got insights into the incidence and prevalence of lupus in the United States. And again, I think it's important to keep in mind that especially our young patients can be at higher risk of complications, not only that we think of traditionally being from lupus, such as increased renal disease, but also cardiovascular disease in those younger patients. So thank you for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on systemic lupus erythematosus. This is Dr. Maureen McMahon for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Systemic Lupus Erythematosus podcast series with our host, Dr. Maureen McMahon. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on systemic lupus erythematosus.